Hello, everyone, and welcome back to our whatever of our podcast. Six, seven, who knows at this point. So we're coming back to do another episode of our Multi-Drug Resistant Organism series. So I'm Fran, I'm one of the infection control nurses, and we have one of our lovely guests with us, Amy Reid, who is a Trainee Consultant Clinical Scientist, who is with us today. And of course...
Hello. And my name's Jen. I'm one of the other infection control nurses in the team. So thanks very much, Amy, for coming to join us today. We are, as Fran said, continuing on with our multi-drug resistant organism mini-series. It's becoming quite a mouthful. So today's episode, we are going to talk about ESBLs. And now we are going to seamlessly segue over to Amy.
Oh, well, thank you very much for having me. And ESBLs is another mouthful yet again. Okay. So ESBL stands for Extended Spectrum Beta Lactamases. So it's a massive group of words. So we'll try and break it down. So basically, these are enzymes that can be produced by bacteria that make them resistant against several classes of antibiotics that we use commonly to treat infections, namely the penicillins, so anything that ends in a cillin, and the cephalosporins, so anything that starts with a keph. So these enzymes, unfortunately, can be spread across many different types of bacteria. Yeah. So when you spoke about your CPEs, you spoke about enterobacterials and coliforms. Mm-hmm. Again, it's the same group of organisms that can possess these enzymes, which can become resistant.
Right, okay.
So these organisms are something that we can all have in our guts, and the resistance develops through exposure to antibiotics. But we screen for resistance in these organisms. We screen for this ESBL resistance in all of our clinically significant isolates that we get from coliforms. So that might be from urines or from wounds or from chest infections. So we're always screening for this, and we will let you know if we find a patient who has this resistance. So it's really important that we look for this resistance because it does make these organisms harder to treat. Not impossible, we just have to make different choices. So we don't use what we would empirically use. We then tweak it a bit. Yeah. So there are options, but it's useful to know. And also the genes that code for these enzymes, they like to move around. They're on a movable part of genetic material called a plasmid, which is basically a circle of DNA, and it likes to hop from organism to organism. So it's important that we have IPC procedures in place for when we find these isolates in significant infections in our hospital patient group.
So could, for instance, the enzymes jump from one resistant bacteria to another?
Yes.
Okay.
Yeah. So these are kind of tricky when you're thinking of hospital-acquired infections and outbreak scenarios, because you may have that enzyme initially in an E. coli, so something that you might have heard out from urinary tract infections, blood culture infections, and then that genetic material could then go into a Klebsiella.
Okay.
So you're no longer chasing a bug, you're chasing a resistance mechanism. So it can make it a lot more complicated. Yeah. So again, that's why it's really important that we're constantly screening for them and having IPC procedures in place.
And that's why we want you to isolate them, people.
Yeah. Yes, yeah, they can be really tricky.
Yeah.
And bacteria are very promiscuous and like to share their
they like to
their
share
genetic material around. Yeah.
How common would you say they are generally in hospital population?
They're getting more common. Yeah. I would say since 2000, we're seeing a really rapid increase.
Right.
Partly because we're looking for them and we recognise them now as being an issue, but also just through the more frequent use of antibiotics. Okay. So you're right, in hospitalised patients, you are more likely to have an ESBL infection than a community patient. But obviously, when we talk about a lot of our elderly population that come into hospital, they quite often sit on that cusp between community and hospital, and they flick-flack backwards and forwards. And they're the patients that are probably more likely to have an ESBL infection.
Are they always clinically significant? Do you always have to treat them?
No. As with any bacteria that's isolated in a clinical sample, it fits into a clinical picture. So if your patient is well, and this is an incidental finding in perhaps a chronic non-healing ulcer and it's not an active infection, no, you wouldn't necessarily want to target your treatment towards it. But if this is noted in a patient's records, which it will be when we've done the testing, it's useful to know, should we have to treat them blind in the future? Because we can make those changes earlier on.
And I guess if you do treat it and it's actually not required, you're just feeding that problem more, aren't
Absolutely,
you?
absolutely. I think the first question to always ask when you have a microbiology result or you have a patient and you're not quite sure which way to go down is this actually an active infection? Okay. What am I treating?
Right.
And it never be a knee-jerk reaction to put someone on antibiotics. Okay. Obviously, quite often we don't have a bug, but syndromically you'll know if someone's infectious or not.
So is this when you, say, pass on to the microbiologist and ask them to kind of determine the correct treatment?
Absolutely, absolutely. And a good example of this is when we have blood cultures that come up positive on patients, we might know that it is a gram-negative rod, which would be what a lot of these coliform organisms look like. So these E. coli, these Klebsiellas. And for every single one of those, we go back through the patient's history and we look for any evidence of ESBLs and CPEs, which you spoke about in a previous episode. And if we find any evidence of those, regardless of what site, we will automatically pick a better option for that patient at the outset.
Okay.
We won't leave them on the empirical treatment.
Yeah.
And if it looks like it's not that organism, we haven't re-isolated it, we'll go on to something else, something less broad spectrum, something more that you would typically use.
Yeah.
Right, okay. Okay.
Yeah, so it does make a huge difference in patient treatment. Yeah. You know, just knowing that the patient is at risk of these organisms.
100%.
So I know what normally happens to me. If I'm on the ward or if it's late in the day and we're having to phone through a result, I might, for instance, speak to the nurse who's looking after them and say, just as an example, so your patient had a urine sample sent on X date. It's come back as it's grown an E. coli, which is an ESBL. What? Can you say that again? I don't understand. And it's, and I mean, when I joined the infection control team, I was like, what on earth is an ESBL? And the way I would sort of explain it to people is it's, as you said, an enzyme that's released by this bacteria, which is inhibiting its being able to be treated. So we have to be, from an IPC point of view, which Fran and I also kind of come on to in a bit, one of the biggest things that we need people to do is isolate patients to prevent those bacteria sharing their genetic material, as Amy's voiced.
And it's also patients sharing that particular bug with that genetic material with each other.
Yes,
so although that genetic material can leap about, there's also the normal IPC of patient to patient, patient to staff transmission of these bugs as well. So so it's quite interesting to do that. And I think a good way of explaining it is so that they don't panic is, you know, this will make it resistant to groups of antibiotics, but there are others that it will still be sensitive to. So take away some of that panic as well, just to let people know that we just make smarter, different choices for that patient.
It's not impossible to treat. We just need to look at them on case-by-case, individualised basis.
Absolutely,
Well, thank you, because I, as I'm sure I've probably mentioned before, I'm a relative newbie to infection control, so I was a bit like, oh my god, I don't know what this is. So it's always good to have
have you had a light bulb moment, Fran?
I think so. I think I need to do a little bit more reading, but it's just like actually having you here and you know what you're talking about. So.
Yes, just about.
So with your newfound knowledge, Fran, what would we then recommend for all of our patients with ESBLs?
So you're going to love us, of course. Something we say every single time, isolation. So patients with a suspected or an active infection need to be isolated, ideally in a single room with ensuite facilities. However, no, that's not always possible. So if there are no ensuite facilities, then ideally they would need their own dedicated commode, dedicated equipment. Equally, we'd like to be able to use single-use or dedicated patient equipment, as I just said. And also, for example, if they don't have an active infection or it's not suspected, then we would avoid placing patients with who are colonised with ESBLs away from those with any catheters because they can be a little bit more susceptible.
And it's probably worth mentioning at this point, I know it's slightly different for other infections that we talk about decolonization and being able to suppress or clear things like MRSA, or in CPEs we do so many negative screenings and then we can release people from isolation. With ESBLs, you cannot actually eradicate them from a patient. You can treat the active infection they have, but because it's normal part of your gut biome quite often, without wiping out all those good bugs that we have as well, it's very hard to eradicate it or decolonize someone. So whereas with MRSA we're treating the skin and we're treating the outside of a patient, when we talk about CPEs and ESBLs, we can't treat the inside of the patient the same way.
No.
So we have
Can't we do a Donald Trump and drink a cup of bleach?
You could try. You could try. It might quickly get you onto DCC, but yeah, it's just worth noting that the way we deal with these bugs is different depending on where they are in you to start with.
Absolutely.
Yeah.
So on that line, what we have had situations before where it's sort of a patient's isolated and they've been treated for, say, for instance, a urinary infection, which we know is an ESBL. What we have done, and perhaps this is the wrong call, perhaps we need to rethink this, is if they have been treated with antibiotics because it was deemed to be clinically significant, we then had to triage the side room availability. Somebody else has required a side room. We would have moved that patient out, and obviously, ideally not, and ideally they would go back into a side room as soon as one is available, in order to triage a potentially more infectious patient, such as someone with a respiratory virus. But if we did need to do that, would you always recommend, even if they've been treated, and obviously looking at it on an individualised risk assessment basis, them always being re-isolated for the remainder of their admission?
I think that really comes back to a case-by-case basis.
Yeah.
So say you have someone in isolation, it's a urinary infection with an ESBL. You've treated them adequately and we're confident that that organism is no longer causing them a problem and an active infection. The likelihood is for a period of time after they've been treated, you have eradicated that ESBL. Yeah. You know, that's not to say that they won't encounter that organism again in the future, but there will be a window of time where transmission is a lot less likely. So it would really depend on where that patient was going afterwards. You know, if they're coming out and then discharging, then there's very little risk. There's very little risk if they're coming out and having a short period of time in a well-nursed bay in the sense of IPC, then, you know, the risk is low. I think it depends a lot on what it looks like at the time and what the treatment plan was at the time.
And exactly how many drips and drains they have in.
Absolutely.
Each one of those inorganic materials are perfect for those bacteria to cling to, aren't they?
Absolutely. Yeah, absolutely.
Great environment.
Also,
moving on to PPE requirements. So we're looking at using our transmission-based precautions. So obviously your aprons, your gloves, and also ensuring that changing of gloves in between tasks is taking place. And obviously good hand hygiene as per usual.
Yeah, it can be really tempting to, once you've got those gloves on, just think, oh, I'm good now.
Do everything.
And you're perhaps helping that patient with some personal care. If you're then accessing their intravenous line or you know, or doing any other sort of slightly more hygienic task, if you like, you must make sure you're taking off those gloves, as a minimum, gelling your hands and applying fresh gloves prior to carrying out any other activities.
Absolutely. And do you want to do the best bit, cleaning?
Our favourite topic. So we our green wipes, our green universal wipes provided by Clinell, they will eradicate those bacteria, and they will eradicate ESBL enzymes as well. We need to make sure that we're cleaning any reusable equipment that's going in and out of those patients' rooms, paying special attention to, you know, the OBS machines. They are all over the patients. They've got to be cleaned in between use, please. Yes. We don't want any double dipping. This is part of our domestic services. They, when they're cleaning pieces of equipment within the room, it's a clean cloth for each task, and following the new national cleaning standards colour coding formula that the domestic services follow. When a patient leaves a side room, whether or not they're discharged or transferred, that room needs an amber clean.
Absolutely. And also, a question that we get quite a lot as well is, am I safe as a staff member looking after patients with ESBLs? So if you're spending a lot of time with positive patients, I mean, yes, on the whole, as long as you're using your PPE correctly, you're washing your hands, then you should be safe. It's just ensuring that we have those measures in place to prevent that transmission. But if you've got any specific concerns, as we said before, just discuss with your line manager. If you can discuss with us if you have any more questions. But yeah, and also visitors wise, again, not a problem for healthy people. We just advise that they do their hand hygiene before and after contact, as we would with the 5 moments of hand hygiene anyway. But typically should be nothing to worry about. So we wouldn't say that visitors are at that much of a risk.
I think it's worth noting that these organisms are you're no more likely to catch them visiting a patient in hospital than you would any other bacteria that may be on a patient.
Yeah.
Regardless of the ones causing infections, all the normal ones that we have on us anyway. The thing that we are worried about with this is it makes us make those different choices.
Yes.
Yeah.
And sometimes those choices are the antibiotics that we would rather not use. They're the ones that we want to keep back and the ones that we want to keep working.
Yeah.
So, it's not any more of a risk to staff than any other bacteria they may be treating in a patient. It's just we need to be careful that we don't overuse these really precious resources of the ones that we watch and
the sort of top
hold
echelon.
back. The top echelon, the sort of domestos of antibiotics. We like to keep
reference.
those. Yeah, we like to keep those close to our chests in micro.
Yeah.
We don't give them out very often.
If you're thinking of any like key take-home messages for people who might have listened to this and it's been like a bit of a barrage of information, what would be your key take-home messages for staff members working on a ward? Say, for instance, a care of the elderly ward. If we went up and told them now that a patient was ESBL positive in a wound swab or something like that.
I would say don't panic.
Absolutely.
It's nothing, it's no more risk to you as a member of staff working with that patient, and it's perhaps no more risk to the patient. The only change we have to make is which antibiotics we use. Yeah. And knowing that information makes us make smart choices. So we ask, like I said, we do screen for it in every single significant isolate that's in this coliform group that we would consider most likely to have ESBLs. So it's just about making smart choices, whether that's antibiotic choice or IPC choice and isolating the patient really. But nothing to panic about.
Yeah, exactly. I was going to say we use a lot of big words, and I feel like the bigger and bigger they get, and like the more combination of words, the scarier and scarier it sounds. So
absolutely,
sometimes the more confusing, but hopefully this has helped to alleviate any of those confusing aspects. And obviously we are always here for questions. And I think this will actually probably bring to a close our multi-drug resistant organism mini-series.
I'm like glad I don't say that again, but
until we find the next one.
Oh my God, don't. Can you imagine?
What might be the next superbug? We'll have to wait and see.
We'll be back for a bonus episode.
Gonorrhea is a pretty popular one at the moment.
Gonorrhea is on the rise. Syphilis is on the rise, but thankfully syphilis isn't displaying any resistance mechanisms. So we won't be talking about syphilis anytime soon.
Well, on that super cheery note, I would like to thank Amy so much. That was really, really helpful. And I think it definitely did a way better job of explaining ESBLs than Fran and I could ever do. And we will thank you very much for listening. And we'll look forward to seeing you on our next episode.
Yes, absolutely.
And we are hopefully going to have another special guest next time.
We're going to be discussing some interesting infection control things coming up, so I believe, but you'll have to wait and see.
One final plug from me, sorry. Just wanted to highlight our study days that are coming up. So we have a C. diff county-wide study day on the 4th of July. There's it's actually next week, so if you want a spot, you've got to really hurry up. And we have our IPC in Action study day, which is just done by our in-house team, which is on Wednesday, the 4th of October at Bowden Hall. So we've still got lots of spaces available. So please send us your interest to the acute ICN address.
Yeah, it's going to be a really good, interesting event. Lots of speakers, lots of things to go and see. So,
and freebies. We'll have pens, maybe post-its.
Prizes, definitely.
Prizes.
got a couple of prizes on the way, lunch, all the good things. So as we've previously said before, if you need to contact us at all, obviously it's extension 6122 for Gloucester, extension 3129 for Cheltenham, or you can send an email to our acute ICN email address. And as usual, any feedback on the podcast at all, we would love to hear it, anything at all. So yeah, just drop us a line and we'll, that'll be great. So yeah, we'll see you next time.
See you next time. Thank you. Bye.